Yeah, great.
Okay, I would like to present our research on resting state functional fMRI study of Sertraline treatment in non-suicidal self-injury adolescents with depression. I think I can skip some of the first few slides about major depressive disorder and SSI as we have talked before. So fMRI as a non-invasive, dynamic, and objective imaging technique can assess the brain of the subject from both functional and structural perspectives. As we know, Sertraline, a selective serotonin reuptake inhibitor, is known for its strong receptor selectivity, minimal adverse effects, and varying degrees of cognitive function improvement, making it a first-line treatment for depression patients. Sertraline is the first SSRI approved for use in children and adolescents with depression. It exhibits effective therapeutic effects for anxiety and depressive disorders in this age group, rapidly alleviating symptoms and enhancing cognitive function, thereby improving the overall quality of life. Some studies have explored the use of sertraline in the treatment of adolescent depressive patients with an SSI, confirming the drug's effectiveness and safety in this population. However, such research is limited in number and has not delved into the neuroimaging mechanisms. Currently, there is a lack of neuroimaging studies related to the treatment of non-suicidal self-injury adolescents with depression. So the objectives of our research is first to analyze the differences in whole brain, local brain activity between adolescents with depression accompanied by an SSI, adolescents with depression without an SSI, and healthy controls. Explore neurobiological markers associated with adolescent depression and an SSI behavior. And two, by analyzing changes in whole brain, local brain activity before and after sertraline treatment in adolescents with depression accompanied by an SSI and those without an SSI. This study aims to investigate alterations in neuroimaging characteristics of adolescent depression patients resulting from sertraline medication. This research seeks to provide more theoretical and treatment-based evidence for the future treatment of adolescents with depression accompanied by an SSI. So here are the inclusion criteria and exclusion criteria for our patients. This study employs the following assessment tools and questionnaires. First, communicate to a research team's self-designed questionnaire menu and Hamilton Depression Rating Scale, Hamilton 17, and the patient questionnaire patient health questionnaire 9, and Ottawa self-injury inventory. We use SPM 12 and REST Plus toolkit within MATLAB for imaging processing and analysis. Here are the research protocol for our study. In this study, patients are treated with SSRI medication, especially sertraline, with an effective dose of 100 to 115 milligrams per day. The selection and administration of the medication were carried out under the professional guidance of clinical physicians. During the treatment period, no other therapies, such as psychotherapy or physical therapy, were employed. All participants and their families were fully informed about the specifics of the study, including indications for treatment and potential adverse reactions. This table shows the first part, the research one, demographic and clinical characteristics results. There were no significant statistical differences among three groups in terms of gender, age, or education level. Significant differences were observed among the three groups in Hamilton and PHQ-9 scores. HAMD and PHQ-9 scores were slightly lower than in the NS-MDD group compared to the NNS-MDD group. Okay, the table shows brain regions showing alpha differences among the three groups. These three figures showed brain regions showing alpha differences between these three groups. The red part indicates higher values in the former, while blue indicates lower values compared to the latter. And this table shows brain regions showing real differences among the three groups, and also the brain regions showing real differences among this group comparison. And this table shows functional connectivity alterations in NS-MDD patients compared to NS-MDD groups. Pearson correlation analyzed results between real FC differences in NS-MDD group patients compared to NS-MDD patients and clinical scale scores. And the red figures shows correlation, and orange suggests a near correlation. So the results of the first part of the study shows that first, adolescent MDD patients show abnormal local brain activity in multiple regions compared to healthy controls. And two, NS-MDD patients have altered local activity in the parietal, frontal, and temporal lobes compared to NS-MDD patients, indicating abnormal brain function in areas associated with emotion regulation, reasoning, visual processing, reward, and attention. In NS-MDD, increased right occipital lobe activity correlates negatively with self-harm frequency, suggesting a link to impulsivity and cognitive issues. NS-MDD patients display increased functional connectivity between various brain regions, indicating problems in memory, self-reflection, and visual information processing. Adolescents with depression and NSI have lower depression-related scale scores, possibly due to emotional relief from an SSI. Longer-term follow-up is needed for further validation. Here is the second part of our study. This table shows demographic and clinical characteristics before and after treatment in different groups. And for NS-MDD patients, there were no significant differences in ALF, FOF, and REHO indicators before and after treatment. However, there was a significant decrease in HAMD-17 scores, where no significant differences was observed in PHQ-9 scores after treatment. In contrast, for NS-MDD patients, both HAMD-17 and PHQ-9 scores exhibited statistically significant differences before and after treatment. Despite a decrease in self-harm frequency, it did not reach statistical significance. Furthermore, NS-MDD patients showed significant changes in brain activity in ALF and FOF indicators before and after treatment, while no significant differences in REHO indicators were observed. And here are tables showing brain regions showing differences in ALF before and after treatment in NS-MDD patients. And this figure shows brain regions showing differences in ALF before and after treatment in NS-MDD patients. And also statistical analysis of brain regions showing differences in ALF before and after treatment in NS-MDD patients. And this slide shows differential brain regions in NSMDD groups before and after treatment in alpha-alpha. And also brain regions showing differences in FC before and after treatment in NSMDD patients. Pearson correlation analysis results between the differences in alpha and FC brain regions after treatment in NSMDD patients and the changes in clinical scale scores shows here. So we can draw a conclusion that after sertraline treatment, NSMDD patients did not show significant changes in local brain activity, but their HAM-D17 scores significantly decreased. This suggests the cognitive function might still be in recovery, and the treatment effectiveness may not have fully met expectations. In NSMDD patients, sertraline treatment led to significant reductions in depression scores on various scales and a decrease in self-harm frequency. Multiple brain regions, including those in the reward, visual, and default mode networks, showed reduced local brain activity. This indicates that sertraline treatment might improve abnormal brain activity and clinical outcomes in NSMDD patients, such as reduced SSS thoughts and improved mood. After treatment in NSMDD patients, the FC between specific brain regions, including the left optiomiddle frontal gyrus and the right superior frontal gyrus, correlated positively with changes in HAM-D scores. The FC between the right anterior occipital lobe and the perihippocampal gyrus showed a trend of negative correlation with changes in HAM-D17 scores and self-harm frequency. This suggests improvements in visual pathways and cognitive function post-treatment in NSMDD patients. In study 1, using alpha-alpha, REHO, and Arroy-based RSFC analysis methods, we found that adolescents with depression, whether with or without non-suicidal self-injury, exhibited altered brain function in regions such as posterior cingulate gyrus, frontal lobe, and parietal lobe compared to a healthy control group. Notably, those with combined NSSI showed a typical brain activity in these regions, which are essential components of the DMN and the VN. Furthermore, self-harm frequency was negatively correlated with alpha in the right canus, suggesting that NSSI behaviors influence brain activity in adolescents with depression. Interestingly, combined NSSI patients had slightly lower depression scale scores, indicating that NSSI behavior might elevate depressive emotions and modulate brain function. In study 2, we investigated the impact of the medication on brain function in adolescents with combined NSSI and depression. Using the same evaluation metrics, we found that program has limited effects on brain activity in non-combined NSSI patients, suggesting inadequate treatment outcomes. In contrast, combined NSSI patients exhibited changes in brain activity in regions like the frontal lobe, occipital lobe, and temporal lobe after receiving medication treatment. This was accompanied by improvements in depressive emotions and a reduction in self-harm frequency. This suggests that program has a regulatory effect on abnormal brain regions in combined NSSI and depression patients. It appears to be effective in this group, with NSSI behaviors potentially leading to distinct mechanisms of localized brain function impact during medication treatment. Okay, so our studies also have some limitations. First, the small sample sizes may introduce heterogeneity among patients, and the lack of placebo control group and absence of pre- and post-MRI scans in healthy controls make it challenging to rule out the influence of the disease progression and time on the brain function results. And our follow-up duration is relatively short. So our research team is currently working on expanding the sample size and conducting further investigations into the neuroimaging of adolescents with MDD who engage in suicidal and self-harm behaviors. Additionally, we are refining our experimental design to account for disease progression and the potential influence of time on brain function. Building up on the findings of this study, future research should consider extending the follow-up duration to assess the long-term effects of the illness and treatment on patients. Okay, thank you.